The case week 6 was on a 65-year-old female with hand tingling. Recapping the history of present illness, she had hand tingling that began about a month prior. She noted it on her drive to and from New York City. The tingling was in the 4th and 5th digit of the right hand only. She noted it as falling asleep but denied true numbness. She did see a chiropractor in New York for a couple visits with minimal help, and it was increased with activities such as reading, driving, playing the piano, combing her hair, sleeping, and putting away the dishes. Her past medical history was significant for a motor vehicle accident 30 years prior where no care was given. Surgeries included an appendectomy and tonsillectomy and 2 C-sections. She's currently taking blood pressure medications and seeks her allopath yearly for checks on her blood pressure and cholesterol medication. When we look at the focused review of systems, we need to identify what system could be generating the primary symptom and or what other body systems may be related to her chief complaint. So we need to look at vascular. Could there be coldness in one extremity? So is one hand warmer or colder than the other side? Could there be color changes? Is one more pale, more blue, more red than the other involvement? Did she note any swelling at the joint? Although we do not expect swelling in this case because it was a non-mechanical traumatic onset, though if there was swelling, we need to be concerned more. So could this be some non-mechanical issues such as gout? Neurologically, is there any tingling, any true numbness, or any true weakness? Often patients will describe that their hand is weak because they're dropping things, but they do not actually have true objective weakness. If tingling is present, or weakness for that fact, we need to look at, does it follow part of a dermatonal or nerve lesion, such as a radiculopathy? Does it follow part of a plexopathy or part of a peripheral nerve lesion? Is Desjardins triad present? Musculoskeletally, are there other joints in the kinetic chain involved? In her additional health history, her activities of daily living were not limited. She was able to get dressed without issues, though did note that she could not play the piano for more than 15 minutes without the hand tingling. She did have some difficulty sleeping. She would occasionally wake up because her hand was tingling. She would reposition herself and fall back asleep again. In our differential diagnosis, we need to be thinking about predominantly thoracic outlet syndrome. The areas of limitation in her life are all related to shoulder movement, as we identified in lab last week, which should lead us to the thoracic outlet. We could also be looking at an ulnar neuropathy at either the tunnel of Guillain, the cubital tunnel, or within the ulnar groove. We should also be looking at a C8 radiculopathy, most likely due to degenerative joint disease, possibly degenerative disc disease, given the motor vehicle accident quite a few years ago. When evaluating thoracic outlet syndrome, we need to remember there are 3 subsyndromes: scalenus anticus, costoclavicular, and pectoralis minor syndrome. So understanding that the neurovascular bundle under the scalene triangle or the interscalene triangle can get compressed in the costoclavicular space, and then the axillary artery can get compressed underneath the pectoralis minor muscle. Our physical exam needs to start with vitals if they have not already been done. If not, we start with inspection. We're evaluating for upper cross syndrome in this case. Is there an anterior head carriage? Is there a protracted or an elevated scapula? Is there winging of the scapulae posteriorly? Want to palpate the entire kinetic chain of the cervical, spine, shoulder, elbow, forearm, wrist, and hand. Range of motion of the above joints to see if there's any involvement in the entire kinetic chain. Orthopedic testing, since thoracic outlet syndrome is our predominant diagnosis or a primary differential, we want to start with thoracic outlet testing. Ruse test screens all 3 regions of the thoracic outlet because in the position of Ruse, the patient is activating their scalenes, narrowing the costoclavicular space, as well as stretching and activating the pectoralis minor. If Ruse is positive, then we need to figure out which region in the thoracic outlet is bringing on the symptomatology. So we will start with Adsons. Adsons would be our gold standard. If the patient cannot turn ipsilaterally or cannot hold their breath, then Halstead's would be a better alternative. We'll then look at Eden's test for costoclavicular syndrome and Wright's test for pectoralis minor syndrome. Looking at ulnar neuropathy, would palpate the cubital tunnel as well as Snell's elbow over the groove. C8 radiculopathy would follow our normal processes of foraminal compression, If negative, then going to Jackson's. If negative, then going to maximum foraminal compression test. Shoulder distraction test can also be done to see if it eliminates the symptomatology in her hand. And if wanted, you can also add shoulder depressor or other cervical spine tests. Our neurological exam would consist of the C8 nerve root evaluation of both motor and sensory, as there is no reflex associated with C8. If somebody has thoracic outlet syndrome due to posture, we would not expect any true neurological findings. If there is a growth within the thoracic outlet, such as a Pancoast tumor or an apical tumor of the lung, then you would see potentially true neurological loss. But in the postural thoracic outlet syndrome that we were talking about in this case, it is unlikely we'll see any true neurological findings. If true motor or sensory findings are found, you must think radicular or potentially peripheral neuropathy. The management of thoracic outlet is going to be managing upper cross syndrome, but first you need to make sure that the neurology in the area is functioning optimally. So adjusting the cervical and thoracic spine for any misalignment would be important. Adjusting the clavicle, first rib, scapula, and humerus will also help decrease any joint dysfunction that exists. Patients also need to be given some stretching exercises, such as the door frame stretching or stretching in the corner of a wall, usually done initially at about 45 degrees of shoulder abduction, moving to 90, moving to 120. As noted, these can alternatively be done in the corner if the patient does not have a door frame that is suitable to do the stretch. Also, introducing the patient on how to put themselves into Brugger's position will help decrease this anterior head carriage and upper cross syndrome that is seen in this image. Having them externally rotate their shoulders, retract and depress their scapula and hold that for a few seconds. I have found that it helps. Having them do this a few times throughout the hour, every hour of the day, helps them start to readapt to a more neutral posture, opposed to giving them certain sets and reps to do. There are also other exercises in terms of strengthening that can be done, strengthening the rhomboids, the middle and lower fibers of the trapezius, and abdominal core exercises, as well as abdominal breathing exercises. You will be learning more of this as you work through the curriculum in some of the functional restoration courses that you are going to be taking.